And if not, maybe you can just get on your phones or your own computers or something. So you all have the link, and it's in this chat here if you want to share it. And I just wanted to introduce Alysha, who is awesome. She's a pediatrician in Kelowna, and she's been really instrumental in the pediatric wing of the real-time virtual support program, the Charlie program. So she's helped us with many hard calls, and she also is a real keen educator and sim expert. So it's just been such a delight having you here, Alysha. And thanks so much for taking some time to speak to the residents in Prince George today.
Oh, well, thanks, Bryden. That's a very kind introduction. Yeah, so it's nice to meet you guys. I did tell Bryden I wasn't supposed to be on service today, and as you can see, I clearly am on service due to some staffing issues. So I come to you directly from the NICU at Kelowna General Hospital, and hopefully I will be able to spend all this time with you guys. So we technically have about an hour together, maybe 50 minutes. I'm going to share my screen. Just a second here so that I can figure all this out. Okay, I'm assuming I'm sharing my screen now. And so I think I was going to initially talk to you guys kind of about like a sick neonate, and I am going to present a neonatal piece for us to go through. But I also have some other kind of general pediatric topics, understanding that you guys are family medicine residents. In a more rural-based program, just to touch on some other topics. And I think I am going to be speaking with you maybe another time later in the year, so there's more stuff we can go over. So this is my disclaimer. I'm a community pediatrician. I'm not an emerge doc, a neonatologist, or an intensivist, although I definitely have interest in all of those areas. I do work in a community-based hospital. Kelowna, we're sort of a medium-sized hospital that is rapidly growing. I am an advocate for education and quality pediatric care. I do love sim, and I have 2 young boys myself. So that's kind of a little bit about me. I trained at BC Children's, and I'm in my 6th year of practice. I work here and I work for the Charlie program. So we will just dive right into this case here. I welcome questions. I would love things to be interactive. You guys can put things in the chat box and I'll try to remember to check that as well. And at the end, I can also give you guys my email if there's follow-up questions or anything. If you ever have anything you want to talk about, you can give me a shout. Okay, so let's talk a little bit about babies. So I'm going to give you guys a case here, and we're going to go through the case, and this is going to be a very like newborn neonatal NRP focused case. I think this is really important, especially as rural family physicians, even if you're not planning on doing like GP obstetrical care, these things walk into hospitals sometimes, and you can't predict what's going to happen. So I kind of did a case a little bit more like that then, rather than having you guys be kind of like right there for the delivery. So we're going to talk about a term baby who was born at home with a midwife. Unfortunately, when the baby was born, they were flat. They came out with no respiratory effort and no heart rate. They are currently on their way to your local hospital with EMS. The vital signs you've been given over the phone are as you see there. So the heart rate is currently being measured at around 30. They are bagging. There's no spontaneous respirations. The baby's temperature is 34.5. All we know is that this is this woman's first baby and that the pregnancy was largely uncomplicated. It was a term gestation and a planned home birth. So knowing this, are there any other questions that come to anyone's mind right off the bat that you want to know?
Do we know the gestational age of this little one?
Yeah, it was 38.5.
Oh, sorry. You must have just said that.
That's totally fine.
Do they have NRP trained?
Pardon?
NRP trained personnel where they're presenting to?
Yeah, so they're presenting to you. So it could be that you're NRP trained. It could not be. I don't know if the EMS, the midwife attending should have had NRP. So they should have been following that algorithm. Yeah. So if you were in a local emerge in sort of like, let's say like a Powell River type setting, and you heard that this baby was coming in, is there anything that you would want to sort of get ready when you're anticipating the arrival of this baby in terms of equipment or personnel?
Yeah, I would definitely want to make sure that I have like an adequate airway like station kind of set up in terms of the increasing sequence of intervention, including likely having to intubate this little one. And then also make sure I have everything in line to do like an umbilical venous line. And yeah, probably would make sure I have that. I'm guessing that I have my little panda warmer or whatever, like the recess. I mean, they're called different things in different places, but just like the recess bay with the with like hooked up to oxygen. Yes. Sometimes I hear it's called a panda, sometimes it's called different animals, but that guy. I want to make sure that that is on functioning, that all my I have like all my airway supplies there. I have appropriate monitors set up. I have all my backup airway set up, including like all my backup tubes, my stylet, emergency airways, and then everything to do a venous line if I have to do that.
Good, yeah. So setting up for a neonatal resuscitation is probably a little bit different than setting up for any other type of resuscitation, because the way that we approach these babies is a little bit different. So that's excellent. If you have those supplies available to you, typically, we call those a panda warmer or a neonatal resuscitation bay. Most places seem to have them. And if you don't, then you can gather up whatever kind of equipment that you have in terms of being able to support an airway, to be able to get some sort of access and to be able to keep a baby warm. Okay, so before we jump into sort of the nitty gritty of how to manage this, I thought we'd very quickly go over in broad strokes some of the physiology related to fetal transition. Because, you know, if we keep ourselves based in our physiology and remember these things, it kind of helps guide our clinical guidance. So what babies need to do when they're born is they need to take breaths, because when they take breaths, it allows them to do the things that are listed there. So in order for a baby to transition from being kind of a fetal circulation to a newborn circulation.
For me, and now it's being transferred and I don't enjoy it.
It's okay. Was somebody maybe not muted? Just FYI. Oh, there's some people there. I see them sitting there. Okay. Yeah, so babies have to take a big breath. The lung expansion allows for the pressure to be increased in the lungs. So your PVR, your SVR kind of go up, and then the pressure, will drop in your pulmonary pressures. This allows for alveolar fluid clearance, lung expansion, and then allows for the initial kind of closing of those fetal shunts. And not necessarily just closing, but the switching of the circulation from like a right to left to a left to right shunt to provide adequate systemic perfusion and pulmonary perfusion. So if the baby isn't taking breaths or those breaths aren't appropriate, then the fetal transition doesn't happen appropriately. And that's what we're really trying to support when we're talking about newborn resuscitation, is that fetal transition. I don't know why. Okay. Whoops. So you guys have probably all seen this picture many times. We see it a lot in medical school. It's just a good reminder about what fetal circulation is all about. I'm going to go over it in a lot of detail with you guys, but it's a reminder that in fetal circulation, essentially the blood is bypassing the lungs through, and then when babies are born, and then we need to oxygenate and ventilate through the lungs, through taking the breath, then sorry, my computer's telling me my internet's unstable. So if at any point I freeze, tell me. Through taking those initial breaths, then all those pressure changes are going to help that transition happen appropriately. All right, so neonatal resuscitation, because of what I just talked about, is all about ventilation, okay? It's all about establishing ventilation, which is a bit different, especially based from adult resuscitation, which is really about cardiac, right? We're all about compressions and cardiac status and circulating that blood, whereas in the neonate, we're all about trying to establish that ventilation. So I can't really see all of you guys, but has anybody taken NRP? I don't know if
you have one thumbs up there.
I have one thumbs up. Okay, so some people have taken NRP.
We all have.
Oh, you all have. Oh, good. Is that part of your program?
Yeah, so I think some of the R1s may not have yet because they do it a couple different times in the year, but all of the R2s who are on, I actually can't see everyone who's on too, but all of us R2s
okay.
have done it.
That is wonderful, because I was going to say, if you haven't, you should, and then try to keep up with it. NRP requires like an every 2-year recertification. And it's really a good thing to just kind of practice. If you guys have access to SIM, anytime you are able to just practice going through those steps, it's really important. This is an old kind of NRP algorithm. It's still the same. It gets updated every few years. But the algorithm is entirely based on establishing ventilation. So you can also get pocket cards of this. It's just handy to have around. So let's go through this a little bit in detail as it relates to our case. Actually, one quick question first. Do you guys know like at what age we stopped doing NRP and moved towards like a PALS ALS algorithm?
I do not. I don't know if anyone else does.
It's a bit of a trick question. And we get this question all the time. So technically a neonate is considered to be any baby under 28 days of age. There's a little bit of, practice variation. Some people say, it kind of depends on the presentation. I basically say under 28 days of age, no matter what the presentation is, if in a resuscitation situation, you're still going to be focusing on ventilation. So a lot of neonatologists and intensivist practice is to do NRP under the age of 28 days. After 28 days, you tend to switch to doing a PALS algorithm. And PALS, just as a sidebar, compared to like ALS, still focuses more on ventilation than it does in adults, but that focus kind of progressively gets less as the person ages. So even if you have a neonate that's presenting to you at 14 days of life, who's in a arrest situation or respiratory failure situation, you should follow your NRP algorithms. Okay, so NRP is all based on ventilation. Your baby comes out if you're present at the delivery, or you receive them even 45 minutes after they've been born. You're going to start from the top, right? What is this baby? Are they term? Are they breathing or crying? What is their tone? You're going to try and stimulate them to see if you can get them going. If you can't get them going at all, or they're not having adequate respirations, that's when you're going to start your positive pressure support. So in this case, this baby that comes in rolls into your emerge, they're being bagged, there's no evidence of spontaneous respiration. You transfer them to your warmer, you give them a good stimulation, which you can absolutely do while somebody's getting their leads on and their probe on. You can give them a good stimulation, see if you can get them going. When that doesn't work, that's when you're going to start going down your algorithm of Mr. Sopa. So Mr. Sopa really is your friend. I often suggest that wherever you are working, that any place that babies are going to be born, there's some sort of visual cue on what Mr. Sopa is and how to follow it. And it's basically the steps that you're going to go through when you're trying to establish ventilation. So you do them in clumps of 2. So MR, then SO, then PA. The newest version of NRP says that you should be moving through Mr. Sopa kind of as quickly as possible. So, counting about 5 to 6 breaths in between each step before you move on to the next. And my tip to you is that if you have someone, just one person's job to be listening to the heart rate and the air entry the entire time as you go through Mr. Sopa. They don't stop, they just listen, because you can actually start to hear your changes. Because the whole goal is to try to increase that heart rate and try to get ventilation. So if someone's listening the whole time, then you're able to actively hear if you're making any progression. So a few more things about Mr. Sopa. Mask size and seal are really important, especially for people with big hands. I don't have that problem, but just be careful that you're not occluding the airway when you're trying to hold the mask in position. It's really easy and nice to just use your thumb and your forefinger to push that down. Assess your mask size. So if you're getting any leaking and you're really having to push the lips in, you might need a bigger mask size. A shoulder roll can be really helpful for repositioning the head. Suctioning the oropharynx, you can go down a little bit farther if you need to. And sometimes I actually have to stick my finger in the baby's mouth to actually open it up and then kind of position their mouth to open it properly, because sometimes they are really clenched down. And then you start to move through your pressure increases. So we go from 20 on 5 to 25 on 5, 5 or 6 breaths. If things aren't improving, then you move right to 30, not on 50, 30 on 5. And then where you can think about your alternate airways. I can't say enough about LMAs, especially in more resource limited settings. For term babies, they're a super important resource. So here at our center, we use the eye gels. They're very easy to insert. Again, I would suggest practicing if you guys have access to neonatal stimulation equipment. They're a really good adjunct if you don't necessarily feel comfortable with an intubation, or you need something while you're getting set up for an intubation, or while you're getting someone in that is more comfortable with an intubation. They can be really helpful. So have those around, know how to use them, practice with them. So neonatal intubation pearls, this is something that you're probably not going to do super often. I don't even do it super often, but if you have to, these are the things to keep in mind. Babies have really anterior cords and their epiglottis is quite floppy. This is why we tend to use the straight blade, so the Miller blade rather than the Mac blade, because the Miller blade, instead of going into the vallecula as you would with the Mac blade, with the Miller, you just go down and push the epiglottis up out of the way to be able to see the cords. And that's because it's floppy and you need a little bit more pressure to get it out of the way. As I said, you're going to be more anterior than you would ever expect to be. It's tiny. So yeah, so it's a little bit of a challenge, but if you do those things, then you should be able to see it. Picking your ET tube size, it's a nice way to remember. Roughly, less than 30 weeks is a 2.5, 30 weeks to almost term is a 3, and anything around term should be a 3.5. We always use uncuffed tubes in babies because of airway protection, and we don't want to damage the airway. And then I talked about the straight blade there. I don't think any of you guys will have to use a 00, hopefully, but you may end up having to use a 0 or a 1. The size difference is quite big. Again, look at them, play with them, get to know them. If you can't intubate and you can bag a baby, it's golden, right? So the actual skill that's more important than intubation is bagging. So if you can bag a baby, then you can bag them until help comes. And this has happened in some rural areas. And like I said, an LMA is always an option. I'm going to stop there because that's kind of the airway portion. Does anyone have any questions about that right away in terms of the airway stuff? I haven't looked at the chat, so no. Okay. Sounds good. Okay, so CPR in a newborn. This is what I find the most challenging part, is that CPR is not indicated in a newborn or a neonate unless the heart rate is less than 60 despite adequate ventilation. Because most of the time, if you can adequately ventilate, you're going to get a heart rate that rises into an appropriate rate. Even if a baby comes out without a heart rate, it's very reflexive to feel like you want to start CPR. But if you can go through the steps and establish ventilation, you may not need to do that. So if you have a heart rate that's less than 60 despite adequate ventilation, and adequate ventilation typically does mean getting some sort of alternative airway in there. I will say in clinical practice, if you can't get an alternative airway in and you still don't have a heart rate, or your heart rate's less than 60, and for some reason you can't get an alternative airway, and then start CPR. But do your best to make an attempt at that first, but don't, die on a hill for the alternative airway if it's clear that you need to start CPR. If you're starting CPR, the first thing you need to do is turn up your oxygen to 100%. It's the 2-thumb method. So putting your 2 thumbs over the xiphoid process, and the ratio is 3:1. We reassess the heart rate and the air entry and the rhythm every minute. So as you can see already, in neonatal resuscitation, it's really helpful to have more than one person. Ideally, you have a team of 3, someone that's recording, someone that's doing the listening and putting on your monitors, and then someone who's at the head of the bed leading and managing the airway. in these type of situations, if you have more people, the better, right? You might need someone for meds. You might need someone for like to be a runner. So as many people as you can get on deck is probably better. Epinephrine is indicated if you start CPR and your heart rate remains less than 60. There's 2 ways to give it. So when you're starting CPR, ideally you're moving towards putting in an emergency UV. You may need a second physician for this, but you can give it through an ET. So if you have an ET tube, then you can give it as per the dosing there. And once you get your UV in, you can give it as per the dosing there. I don't think you guys need to memorize these doses. They should all be available to you on things like pocket cards or apps. But they're not too hard to remember either, but I just feel like we have a lot of pressure to remember things. So you should be able to find them. But 1 ml per kilo of 1 in 10,000 is typically, okay, sorry, it's typically, thank you, what's needed. So that's epi. Emergency UVs, again, it's kind of like with any procedure, it's the muscle memory of going through the steps. So if you ever have time, get out a UV kit, look at all the things you have and practice. It's actually pretty straightforward. Basically, you just need to take the cord, clean the area, tie it at the base so that you don't bleed out, hold it up, cut it, and then take your UV, and usually you just need to get to 5 or 6 centimeters until you can draw some blood back. That's all you need for an emergency UV. And then in emergency resuscitation, you would just hold it in place while someone pushes the epi, because you're not going to take time in that moment to suture it, okay? So yeah, again, just try to practice with it. There's 2 different sizes of catheters, but in a term baby, a 5 is extremely reasonable. If it's a really small baby or a preterm baby, just throw in a 3.5 and don't worry about it being too small. You can figure that out later. So just a few other considerations. So meconium used to be part of the algorithm of NRP, where we would always suction below the cords when there was meconium present at a delivery to try to prevent meconium aspiration syndrome or obstruction of the airway. That's no longer part of the algorithm because they found that a lot of people that maybe weren't comfortable with airways, because you had to like put an ET tube in, were fussing around trying to get that done, when really what we needed to be doing is starting to establish ventilation. So it can still be considered if there's an obvious airway obstruction with like thick meconium, like you can go in and try to suck it out, but it's not routine. Naloxone is not recommended as a part of NRP. There's limited data. So even if you have a babe where, mom has just got some fentanyl or something and they come out flat, most of the time you can just support them through bagging while that kind of quickly wears off. And naloxone actually can lead to neonatal seizures, so we shouldn't be using that. As you could see in our case with our baby that I presented initially, babies lose temperature really fast, so especially the ones that are born outside of hospital and coming in, they'll often come in super cold. So especially in the ER, or if you don't have access to a warmer, do lots of considerations about warming. So blankets, warm blankets, you can get some, most places have these pads, these warming pads that you can crack and they will warm up. In preterm babies less than 32 weeks, we actually put them inside a bag to help with their thermal regulation. Sorry, I said less than 30 there. It's typically somewhere between 30 to 32 weeks. And then hopefully you never have to encounter this, but the recommendation for termination of resuscitation is that if you've had no heart rate and no respiratory effort despite over 10 minutes of resuscitation, it's typically recommended to terminate. I will tell you, in reality, the resuscitations go on for a lot longer than that. But I think based on the outcomes, which are found to be not good after 10 minutes, that's when it's sort of ethical to call a resuscitation. I think the only other thing that I didn't put on there that I wanted to say was about oxygen. So as a part of NRP, and again, it's great to have it like on the panda warmer or the wall. Oh shit, guys, I have to go. That's a code that I have to go to. Brendan, I'm coming. I'm so sorry. I will come back if I can. I will send you my case. Okay.
That's no problem, Alysha. No worries. Everyone
Okay.
understands.
I'm sorry, guys. Okay. Bye.
Thank you so much. I don't know that we can necessarily hope that she's going to come back, because she probably has something very important to deal with. So if you guys want to put your emails in the chat, what I'm going to do is send you the slides. And then I'll also send you a little bit of information about RTVS and how to access it, because I don't know if any of you independently have accessed RTVS before, or even with another physician, but it is Alysha herself is on the Charlie pathway, which is the pediatric pathway, but we also have emergency docs. We also have maternity newborn docs, and we also have intensivists, all sort of available to resident physicians, new to practice physicians, as well as nurse practitioners and nurses in rural and remote sites. So that's one of the reasons we like to do these talks, is to sort of introduce you guys to some of the docs, and also to that potential for support in your future careers. Perfect. All right, thanks everyone, unless there's any other questions.
Thank you.
Thank you so much.
Enjoy your weekends.